Good afternoon. I want to welcome everybody to our meeting this afternoon. We apologize for being a few minutes late. Some of our folks had some other meetings going on and wanted to give them a few minutes to get here. We've got a notebook right over here. If anybody wants to sign up when we finish our budget work, we're going to take public comments from anybody in the audience that would like to talk for a minute or two and make a comment or anything. So if you would sign up so we'll have a list and we can get into that. So as we get ready to get started, let me just make a couple of announcements. First of all, we have a new budget analyst with us. This is Margie Miller. She used to be Margie Coggins, but she's Margie Miller now. And we're fortunate to have her no matter what you call her. And also on our committee, Ben Harbin is serving as our vice chair now, and we have two new members, Darlene Taylor and Dr. Ben Watson, and we're glad to have them, and then all of our returning members as well. And as you all know, there's several things going on right now, so we're probably going to have some folks drifting in and drifting out, and we'll just move along. So without further ado, let's go ahead and get started, and we're going to call on Commissioner Cook to talk to us.
Thank you, Mr. Chairman. Can you hear me on this? Okay. Very good. Let me know if you can't hear. Okay. Is that better? Yep. Thank you. Appreciate it. Again, the opportunity to be with you and present the Governor's amended fiscal year 13 budget on behalf of the Department of Community Health. I've got seated to my right here Vince Harris, who's our Chief Financial Officer, and Kevin Tolmick, who is helping with the presentation over here. I had the opportunity to present a lot of background information on issues related to the Department of Community Health at the joint meeting of the Appropriations Committee, and I don't plan on going through all that, although I do have all those slides here, and if there are particular questions you have on any of those issues I've raised, more than happy to refer to that information and try to answer any questions that you might have. With that, I'm going to skip through some of the slides here and go to slide 2. This slide gives you just a little bit of an overview of the Department of Community Health. As you all know, Georgia, the Department of Community Health is Georgia's lead agency for healthcare planning, purchasing, and oversight. And we've got the responsibility for administering two of the larger programs in state government, the Medicaid program and the State Health Benefit Plan program. Those two programs combined cover about 1 in 4 Georgians, so very important programs to the state. We also have health facilities regulation, which involves the licensing and inspection of nearly 7,000 healthcare facilities, including hospitals and nursing homes. And we also have a lead role in health information technology. One of the things that we have going on at the department are several major health IT projects, ICD-10 conversion, the Medicaid electronic eligibility system, both of which are massive IT projects. So we have several of those going on at the department as well. Total funding for the department, and by total funding I'm talking about federal funds as well as other funds, in addition to the state funds, totals in FY13 $11.9 billion. Now if you go to slide 5, I think it is, one of the things I did want to mention and emphasize, I made this point last week and would emphasize it again, that we pay a lot of attention to both the Medicaid and the State Health Benefit Plan. Both are large health plans. We cover a lot of people. It's a lot of money spent through both those health plans, but they're very different in nature, and each require a very different management approach. Medicaid, I guess one of the surprises or things I've learned over the course of the last couple of years is how restrictive Medicaid is in terms of what we can do and what options we have. It's an entitlement program. We have a lot of federal requirements that we have to meet, and that really limits our management options. On the other side of the coin, the State Health Benefit Plan is a private health plan, And there are several options there, and we've exercised a lot of those options to do some things to really bring down the deficits within the state health benefit plan. Very proud of the fact that we reduced the 2-year $815 million deficit by 92%. We got that down to a $62 million deficit, and did that while creating the largest wellness plan in the country. So we're focusing on wellness and looking at what we can do to hold down costs. And we're also proud of the fact that we also reduced the out-year liability, the OPEB liability, significantly with some structural changes to that plan. Looking at the next slide, this is a pie chart which gives you a breakdown of the total funds within the state health benefit plan. As I've mentioned, Medicaid is the largest program area that has two different areas in red. The age blind and disabled is the largest with $4.4 billion. The low-income Medicaid is next with $3.3 billion, and then the state health benefit plan, which is other funds, premiums, and employer contributions, etc., comes in at just over a quarter of our budget and right under $3 billion. One of the things that's always interesting is Peach Care, which there's a lot of conversation about. It mirrors the Medicaid program is just 3% of our budget. It is not an entitlement program like Medicaid, but follows essentially the same rules. So what I tried to do, hopefully this works for you, I believe you all have a tracking sheet, and I tried to adjust the presentation so it follows your tracking sheet, and we use the same numbers there. So I'll start with the first category that I believe is on your tracking sheet, administration. And within administration, I guess I would make a couple brief points. You can see from the slide here, slide 8, that our administration, which is just DCH, we used to have public health and other factors have been excluded from this calculation. Within DCH, we've reduced our administrative budget 40% over the last 5 years. You'll note that in 2013, there's a little bit of an increase in administration with DCH. There's about a $3 million increase from $64 million to $67 million. That relates primarily to those big IT projects that we talked about, ICD-10 coming on board, Medicaid eligibility. Both those come in with significant federal matching funds, and other than those, we've actually reduced the number of positions in the department as well as the payroll. So let me turn to the specifics on your tracking sheet, and I'll go through these quickly. The 17.1.1 reflects the funds adjusted for property liability premiums, small amount of money there. 1.2 reflects an adjustment to our telecommunications. We actually did a review with GTA, and they believe that we were underfunded in terms of telecommunications and needed some additional resources. Again, I think those are related primarily to the IT projects we had. 1.3 reflects an increase for fund for expenditures which were deferred from prior years. Last year we unencumbered about $10 million in order to try to meet budgetary targets, and those are funds that we would like to have restored to our budget this year, $9.7 million. Item 1.4, we replaced state funds with other funds due to our performance bonus that we had in the CHIPRA program. Item 1.5 reduces funds for the Medicaid eligibility project by a small amount. 1.6 reflects reduced funds in operating expenses, and 1.7 reducing funds in the contract area. Those two areas relate to attempting to achieve the 3% budget reductions that the governor called for in his budget instructions. You can see on this slide, number 10, where we see the savings administration, about $1.9 million, and you can see the various areas that those cuts have come from. I would point out on the third line there, health facility regulation, you see a decrease of $165,000. That's a elimination of 2 positions that we had, and that relates to the geomapping thing I talked about the other day, where we have been more efficient with our surveyors and have been more productive as well. So that allowed us to not decrease the number of surveys that we do, but actually decrease the number of employees that we have doing that. You can see the total reduction there in administration is about $2.4 million. The next item on our program area on your tracking sheet is healthcare access improvement, and the not much difference there. You can see some reductions of total of about $350,000 relating to the Firefighters Burn Foundation, the decrease of that funding there, and 2.2 where we were able to reduce funds for operating expenses in the State Office of Rural Health. We've been able to find federal program money to supplant state funds with that, so we were able to make those reductions as well. So net change in that program area of $350,000. Health facility regulation is the next program area on your tracking sheet. As I mentioned, we license and inspect just under 7,000 facilities. You can see some of the metrics there. This also includes the Certificate of Need program, where we reviewed this last year about 68 applications. The governor is recommending a total budget there of about $15.7 million. The next slide I'm just going to touch on very briefly, but again, commendations to state health facility regulation for doing the geomapping project and allowing us to identify the location of all the healthcare facilities in the state, what their capacity is, the locations where they're located, to allow us to react in emergency situations in a much more informed way. It's allowed consumers to go out. We've had, on a daily basis, we hear from consumers and others about how they've used this site and how it's beneficial. And as I mentioned a few minutes ago, it's helped increase our productivity within the department. And as I mentioned the other day, we are in discussions with Google about their impressions on what we've done, and with the hopes of showing other states what might be done with their mapping technology. Within the health facility regulation, you can see there the $165,000 reduction, which represents the elimination of 2 staff positions within that area. The next program area is the Indigent Care Trust Fund. This has been an area of has some impact this year. As you know, every year there's an appropriation for the deemed hospitals to draw down or get the disproportionate share hospital funding from the federal government. This year the governor has included $6.8 million to provide the state matching funds for the private deemed hospitals eligible for the disproportionate share. That takes us to the big program area on your tracking sheet, the Medicaid program, which is the largest area of our budget. I'm going to skip over some of these historical slides in terms of growth. Medicaid is a program that has grown over the last 30 or 40 years, and I thought the historical data on that is interesting. Today, Medicaid and Peach Care cover a lot of members, mostly children. As you can see, between Medicaid and Peach Care, we have about 1.7 million Georgians that are enrolled in Medicaid or Peach Care. That's about 1 in 5 Georgians, a little bit under that, 17.6%. But the vast majority of those are children, I should say. The majority are children, and about 41% of all of Georgia's children are enrolled in the Medicaid program. The average spend per day in the Medicaid program is about $31 million per day. We pay a lot of claims, and Another interesting fact that we mentioned, there's always a lot of interest in, just under 60% of all the births in Georgia are paid for by the Medicaid program. Medicaid consumes about 17% of the state budget, and you can see that tracking over time from about 14% in 2007 to 17% in 2013. This next slide shows national trends in growth versus Georgia trends, and you can see from about 2006 on we have tracked lower or about equivalent to the national trends in growth, and I think we do a good job in terms of managing the Medicaid program within the restrictions that we all have with regard to the federal restrictions that I mentioned earlier. So we're keeping those trends a little bit lower than the national trends. If you can skip to slide 27, this is a slide that I think is worth mentioning again. As most of you probably know, the largest costs in the Medicaid program are associated with the age, blind, and disabled population, which represents about 29% of the enrollees, but accounts for about 58% of the costs. There are a couple reasons for that. With an elderly population, you would have a more expensive population, and we're also managing the ABD population within a fee-for-service environment. The low-income Medicaid is a capitated payment arrangement where we pay 3 managed care companies capitated amounts on a monthly basis to help manage that program. I talked at length, I think, the other day about the areas that we can manage Medicaid growth and costs. Those areas relate to eligibility, scope of benefits, utilization, and price. Most areas in terms of eligibility and scope of benefits are restricted from any tinkering by the federal government from us changing eligibility or scope of benefits. Our areas for management opportunities are within utilization and price. I think one of the biggest issues of the legislative session is the provider payment agreement, which expires at the end of this fiscal year. You can see in FY 2013 here are the numbers on a graph that indicate that maybe a little bit clearer than it might on the tracking document. We estimate revenues from the provider payment agreement this year of $234 million. We pay back to the hospitals about $250 million and use that money also to generate an additional $434 million, which is used to help support the Medicaid program overall. You can skip over 2014. The other area of impact with the Affordable Care Act this year that I wanted to point out with regard to Medicaid is that, which is on page or item 31, slide 31, the Affordable Care Act mandates a increase in payment rates to primary care providers to be paid at Medicare rates for calendar year 2013 and 2014. You can see on this slide the amount of money that will cost, and those funds are paid for with 100% federal funds, so there will not be a cost to the state of Georgia with regard to that, other than the cost of changing our system back and forth to make those payments. I would note that the rules related to this were late in coming out. That has delayed our ability to make those payments appropriately on January 1st. I don't think the rule came out to almost Thanksgiving, so we anticipate having those computer changes made by the spring, and we'll make those payments appropriately retroactively back to January 1st. So let me try to run through briefly for you the tracking sheet items in the Medicaid age, blind, and disabled portion of the budget. So you can see 17.5.1, there's an increase of about $10 million in nursing home provider fees, and that reflects the additional revenue that we project. We moved to the 2010 cost reports, and we're able to generate that additional money for use in the nursing home area. 5.2 is a adjustment of what we anticipate we'll be collecting within the hospital provider payment agreement. It's a reduction of about $36,000 for FY13. Item 5.3 replaces funds that were included in the annual budget where we projected savings, or there were savings projected, I should say, of about 4 to 1 return on investment for some fraud and abuse activity that we had. The actual return that we believed and actually our resulted was about 2 to 1, so we're asking that $4 million be restored. So we did implement the program. We're still beginning to implement pieces of it, and the return on investment has been about what we projected, about 2 to 1 with regard to that. Item 5.4 reflects savings from eliminating the consultation code under the CPT coding methodology and moving to evaluation and management codes. That saves about $1.7 million, and it tracks the change that Medicare has made, so it'll make Medicaid a consistent payer with Medicare. Item 5.7 reflects savings from reducing the number of narcotic prescriptions to 6 per month. Item 5.8 reflects savings of about $3.5 million through better enforcement of our level of care analysis for both long-term care services as well as home and community-based services. In FY13, we project savings of about $3.5 million in that area. Item number 5.9 reflects savings from eliminating hospital reimbursements for preventable admissions and readmissions. You may be aware that Medicare changed their payment policy along these lines. We're following suit with Medicare payment policy, and you can see a small savings there as well for the Medicaid program. And then item 17.5.10 is the increased funds that we project that we will need in terms of Medicaid growth, about $132 million in FY14. In FY13 this year. We project about a 6.2% increase in expense growth and about a 4.1% increase in enrollment growth for FY13. The next budget area contains many of the same elements. It's the low-income Medicaid. You can see, I'll just reference very briefly the same ones: reduce hospital provider payments to reflect the provider payment agreement calculations that we have updated. Item number 6.2 is different than low-income Medicaid. We reflect savings here by eliminating reimbursements for elective inductions and C-sections prior to the 39th gestational week. So we consider that to be a provider preventable condition. If it's medically necessary, it will be paid for and it will be covered, but there is a lot of data that shows that if you bring a fetus to the 39th gestational week, that there are a lot of benefits down the road for doing that. So that was a change in policy for a number of reasons. Item number 17.6.4 is a shift of using a little bit more tobacco funds within our budget of $8.3 million. Item 17.6.5, again, is that change in CPT terminology, eliminating the consultation codes, which would impact the low-income Medicaid portion of the budget. Item 17.6.6 reflects savings from the number of drugs that we have on the specialty pharmacy list and negotiating a little bit better discounts on some of those specialty drugs, which are more infusion-type drugs and injectables, which tend to be the higher cost drugs. You can see some small savings there of about $133,000. Item 17.6.7 reflects the savings from hospital cost settlements We are truing up those hospital cost settlements from FY 2009, 2010, and 2011. We're behind in this because we were standing up a new Medicaid payment information system. We were not able to do those cost settlements during that time. We got that fully certified and up and running last year, and so we have done a good job in terms of catching up on that. Not sure that we're going to be able to collect all that money this particular year for FY 2011, so that number there, $7.8 million, may be a little bit off. Item 17.6.8, reflecting the savings from the number of, this is the narcotic prescription limitation of 6 per month that I mentioned earlier in the ABD population. 17.6.9 reflects savings from eliminating hospital reimbursements for the preventable readmissions. And then in the low-income Medicaid, we show a increased funds for growth in that particular area of just under $80 million per year, or for the remainder of this year. Our expense growth in this population is projected to be about 4.1% this year, and our enrollment growth is projected at about 3.2%. Peach Care for Kids, as I said, mirrors the Medicaid program. Each of the elements on your tracking sheet here relates to ones that I've already discussed, so unless you have questions on that, I'll just skip to the end where we show item 17.7.6, increase in funds for growth in Peach Care, and we show that growth to be about $9 million in FY13. I believe that completes the Peach Care for Kids, and that takes us to the State Health Benefit Plan, another large health insurance program that we have. I gave you on slide number 41 some fast facts about the State Health Benefit Plan. We cover, as I showed the other day, a host of employers and employees over the state of Georgia, teachers, state workers, and non-certificated personnel. With all of those employees and their dependents, the retired population related to those, we cover about 643,000 individuals in Georgia. As I mentioned earlier, that amounts to about just under $3 billion in other funds. Those state funds are used for this particular program. And claims are about $11.5 million per day for the State Health Benefit Plan. This next slide is a slide I like to talk about because I think it shows pretty graphically the challenge that we have with the State Health Benefit Plan. And it's important that legislators and others know that the State Health Benefit Plan really is 3 plans. It's the state employees, it's the teachers, and then it's the locally funded non-certificated employees. So those are 3 separate plans that are really managed as one plan. You can see from this chart the revenue in blue, the expenses in red, and the deficit in related to each of those plans. And as you can see, we have in the state employees plan, the teachers plan, a surplus in those plans, but we have a deficit in the non-certificated area. Now this has been an issue for a couple of years because the state appropriation related to the DOE appropriation we used to get tapered off and then finally went away over the course of the last couple of years, as you can see from this graph here on page 44. And that helped us bridge the difference between the cost of the non-certificated plan and what we were being paid in terms of employer contributions as well as employee premiums. And as you can see, where the purple line there reflects the costs for non-certificated personnel, and the bar graphs show how close we get to achieving parity or covering the costs of those that in that particular plan. On the far left side, you can see in FY 2008, the green bar portion of the bar there reflects the state contribution that has been eliminated, and you see an increasing red bar there, which reflects the response to that by asking the local employers to pay more or a greater percentage on their local contribution for covering those individuals. There's still a gap between those, which we struggle to fill that void. We do that in part by using the surpluses from both the teachers' plan as well as the state employees' plan, as well as our 3-year plan to help eliminate that gap. As you can see at the end, 2015, even with the 3-year $150 per member per month increase, we still won't be covering the total cost for the non-certificated employees there, but we'll continue to work on that. I'm going to skip to slide number 49. Again, this is a graph similar to our Medicaid graph, which shows national cost trends in healthcare versus our cost trends in the state health benefit plan. And as you can see, we are below the national average. I think the national average over the course of the last 5 or 6 years was 8.4% growth, and the state health benefit plan has about 5.1% growth. So this has driven some savings over the course of that period of time of an estimated $1.3 billion. We continue to look at ways that we can better manage the program, and we have challenges, as I've described, with regard to the previous slides, primarily with regard to the non-certificated coverage for those individuals, but also, as I mentioned the other day, we have some changing demographics within the teachers' population that will also present some challenges down the road. So we're looking at that and trying to manage towards that as we move forward. Slide number 50 kind of highlights some of the changes, the big changes that we have made. Last year we addressed with a 3-year plan the issue that I talked about with regard to the non-certificated employees and trying to bridge that particular gap in funding there. This year, the second biggest subsidy that stuck out at me in looking at the state health benefit plan was the fact that covering spouses, which not all states cover. Some states just cover their own employees. They don't provide spousal coverage or children's coverage. We do both here in Georgia, and I think that's a good thing. But we need to also make sure that our employees are covering about the 25% to 30% of the cost of covering their spouse. So in some areas, in some particular pieces of the plan, the employee was only covering about 3.5% of the cost, not anywhere close to the 25 or 30%. So we have a several-year plan to begin to move that up. So you can see that some employees have had a significant increase, no more than $90 per member per month. And you have to take off of that the $50 spousal surcharge that we were charging as well. So we've eliminated the spousal surcharge of $50 per member per month, which is on the honor system, and you have to disclose this and then you have to pay it. And we felt it was better just to do an objective per member per month payment on that. And so the maximum increase, I think, was $90 per member per month, offset by that $50 reduction. So that was probably the biggest change in the plan this year. Those that didn't suffer that particular premium increase related to those spousal areas had a 7.5% increase in their premiums. And then in addition to that, everybody was hit with about a 2% premium increase to implement the Affordable Care Act requirements related to coverage for women's health services, and as well as the $1 per member per covered life per year clinical effectiveness research fee that was implemented or required this particular year. So take both those two together, that amounts to about a 2% premium increase. Over the last several years, we've seen about a 14.3% increase in premiums as a result of the various mandated aspects of the Affordable Care Act. One of the size of relief we got this year, we can expect to see this next year about this time in our FY15 budget. I think they pushed it out a year. We were anticipating it might happen in 14, which is a requirement that we pay for a high cost reinsurance pool, and we estimate that will be 30, 40. We're not quite sure yet, but $30 or $40 per member per year on that. That will be an impact in FY15. As some of these rules are coming out, they change. So particularly with regard to Medicaid, we got a number of rules not too long ago, I guess 2 weeks ago, 500 pages of rules, and we sift through those. So you can count on things changing as the rules become clarified, as we get more clarity on how all these significant changes will be implemented down the road. So I would say on that particular one, on the reinsurance plan, we dodged a bullet this year, and we can expect to see that come up in FY15. Moving to the tracking document, in item 7 in the State Health Benefit Plan 17.8.1, you can see we anticipate some savings from negotiating rates with through our hospital network of about $5 million. 17.8.2 reflects a 0.5% increase for the employer share in the State Health Benefit Plan from 29.7% to 30.2%. Effective January 2013. Actually, I believe we're implementing that in March 2013. So it's a 0.5% for 6 months, which generates about $6 million. Item number 17.8.3 reflects a $25 per member per month increase for the certificated. This would be the teachers part of the plan, from $912 per member per month to $937 per member per month. The last time we saw an increase from the employer contribution in the State Health Benefit Plan for teachers was 2008. Item number 17.8.4 reflects savings from revising the prescription drug list, making them the same between United and between our HRA and the preferred drug list that's used for the HMO product and the high deductible health plan products. So we're making that preferred drug list uniform across plans, achieving some savings there. Item number 17.8.5 reflects savings from implementing a pharmacy step therapy program. This would be Cigna implementing the type of step therapy program that United currently has in place and making them uniform across products as well. Item 17.8.6 reflects savings from elimination of prior authorization for ADHD drugs. You can see there's not a large dollar amount there, but we were approving virtually all of those, so there were really no cost savings associated with that. Item 17.8.7 reflects the additional add-on, or really I guess you could more accurately consider it a buy-up, payment of $7 per member per month to reflect the higher administrative costs that United is associated with their implementation of our plan. And so if you choose United, then you have the choice of paying the additional administrative costs that go along with that as well. That's about $8.9 million of revenue that we anticipate generating from that. Item number 17.8.8 is the 2% increase that I mentioned with regard to the Affordable Care Act. That generates about $6.8 million. Item 17.8.9 is the 7.5% premium increase that I had mentioned earlier for about $6.4 million. Item number 17.8.10 reflects our investment in our childhood obesity initiative by changing the coverage, adding additional physician services as well as additional nutrition services for children that have been diagnosed as obese. That is in conformity with the governor's initiative on childhood obesity. Item 17.8.11 reflects the increase in the implementation that we have with regard to the wellness plan that we have. I showed the other day the preliminary, or the data that we got from our first year of the wellness plan regarding body mass index and high blood pressure. And so now we're going to be using some of these funds to begin to target some of those specific issue areas with individual patients. And so hopefully we'll see some movement in those numbers, and that'll be interesting to track over time. 17.8.12 reflects an increase for the spousal coverage that I had mentioned earlier. 17.8.13 reflects savings in plan design changes that we have implemented. That will be about a $66 million savings there, which relate to co-pays and all the other plan design changes that we made. And 17.8.14 is our updated revenue and expense projections of $74 million. You can see from the next slide that when you take the net changes to the plan of $81 million, our revenue and expenses, you see that we have about a $19 million surplus, which would be applied towards an $18 million deficit that we had this last year, for leaving a projected reserve fund balance of $1.4 million in the state health benefit plan. Finally, on the very bottom line, I think it's always important to note we don't have coverage for this right now, but we do have an incurred but not reported liability of just under $200 million in the state health benefit plan. It's about the same number in the Medicaid plan. Mr. Chairman, that's a lot of information very quickly. I'll be glad to answer any questions that you may have.
Thank you, Commissioner. That's a good report with a lot of interesting information. If the members have some questions, if you would mash the button by your mic so I can see here to turn on your mic. And so if we have any questions, let's see. I have 25. Who is Ben? Yeah, Dr. Watson.
Thank you, Commissioner Cook. Let me just bring your attention to the, I guess, the spreadsheet there, 17.5.1 under age, blind, and disabled. The increase in the nursing home provider fees to reflect projected FY 2013 revenue. Can you just go into a little detail on that? Is that? I'll let you get there. 17.5.
Yes, sir.
0.1. Is that what just below that, the hospital provider payment, that's done by DCH in conjunction with the nursing homes? That's an increase in the charges there, and is that money rerouted the same way that the provider fee is back to is matched, drawn down, and then rerouted back into the Medicaid program? Is that the way that's done?
It is, and it's a specific line item in the budget, and we increase that provider fee administratively when we get that fee from the nursing homes. That is used to match federal funds, and that those funds go into the Indigent Care Trust Fund, and under the statute that creates that particular provider fee, all of those funds have to go towards nursing home provision of care.
Do you know the percentage right offhand? What their percentage of revenue is? Is that the way it's done? Is it a similar mechanism?
Not sure I understand. The matching is about the same, 6 cents on a dollar.
From the provider,
that would generate another.
What's proposed for the provider payment, I think, is 1.45% of the revenue funds. Is that correct? I think that's about right. Do we know what the nursing home? Do you know how much they're paying? 5.99, and that's the okay.
And there is a federal cap on that of 6% for both hospitals and nursing homes. So we're essentially generating about as much money as we can in the nursing home area to draw down as much federal funding as we can.
And is that similar to the provider fee? Is that 47 states out of the United States that do that, or is that about where we are?
I guess the study I'm familiar with is the Kaiser study, which said 49 states. The only state that did not have some form of a provider fee was Alaska.
Okay.
And several of them, including Georgia, have more than one.
Thank you.
Okay, Representative Hughley has a question for you.
Thank you, Mr. Chairman. To Mr. Commissioner, you on your slide number 26, you talk about how Georgia is lower than all of the states in the Southeast in our cost per participant. Do you have any corresponding statistics to show us how healthy or what the outcomes are for our participants as it relates to other states, participants in other states?
We do have data, and that's pretty widely published data. We'd be glad to get you any specific information that you have. One of the things that I think we're challenged with in the South is that the outcomes and the general health condition in the South is not as good as it is in the Northeast or maybe some other parts of the country, and there are a lot of variables that go into that, from diet and socioeconomic and other factors that figure into that.
One other question, and it relates to where you were talking about reducing the number of narcotic prescriptions to 6. It's going down to 6 from where? Where is it now?
I think it was unlimited. I'm not sure, though. We had no limit on it prior.
So how did you arrive at 6?
Don't know. Yeah, Jerry. Dr. Doverly.
Sure. So when we looked at the narcotic utilization, and we excluded members who had cancer and some chronic disease states, we were looking at where the break fell. And 6 was kind of a natural break where, we really felt that was the point where we started to really see that as starting to be an outlier and at least warrant from being questioned. So there is a process for individuals certainly who need more than 6 prescriptions per month, but it was just a natural break in the data as to where we saw the clustering of number of narcotic scripts.
So if they actually need more than 6, there is a process for them to get there?
Absolutely.
Okay.
Right.
All right.
There are certain disease states that will be excluded.
Thank you.
Representative Gardner has a question for you.
Thank you, Mr. Chairman. I wanted to follow up on a couple things. First of all, to congratulate you for getting a bonus in Medicaid, for doing some good things. Are there more bonuses available?
We go after bonuses where we can.
Well, that's great. I wanted to follow up on the doctor's question about provider fees. The increase here is 10 million, 15.5.1. What is the total amount of the provider fee?
That's the amount we generate from.
So we're adding 10 million to some other number.
Yeah, we anticipate generating additional $10 million from the fee.
Right, it's about 145 million, I believe.
Right.
145 million now, so it'll be another 10 is your expectation. And does all of that go directly to nursing homes and none of it come into the department?
I believe all of that goes into the nursing homes.
Can I follow up a little bit?
I think that's a statutory requirement.
It's in the law.
If my recollection is right.
Okay. Of the ABD population, I've kind of been learning a little more about the ABD population, and I wondered how many of the individuals in the ABD program are actually in nursing homes. Any clue?
It's probably less than 50%, but I would be guessing. You all have
Would you mind?
some. I'd be glad to get you that.
Maybe the.
There are about 29,000 individuals that are in the nursing home, and those do meet an institutional level of care, and with a very small exception.
So it's 29% of the total.
29,000.
Or 29,000.
So if you look at ABD, there are different ways to define that.
Uh-huh.
About 350,000 people in that category.
And of those 350,000, 29,000 are in nursing homes, and the others are in other kinds of homes of various sorts.
Right. In the community or in a home community-based way, what's that?
One last question, Mr. Chairman. I was interested in the state health benefit plan, and we heard some from the community that there were various entities of state government that were going to go to see if they could get a better deal on health insurance. Your statistics make it look like you're doing pretty well in holding the line, albeit on the backs of state employees, which is tough on them. But I just wondered what happened to those folks who went out to try to compare and buy their own health plan. I mean, did they find a better deal in the private marketplace?
We had visits from a number of school systems that were interested in looking at, and we welcome that, how we can manage the plan better, wanting to know what their needs are, what we might be able to do to help meet those needs. Some of them came in with brokers and other people who thought that they could beat the state health benefit plan costs, and they were right until we got to the point of recognizing the fact that they needed to include retirees with that. And once they got to the retiree portion of it, they all decided that they were not able to provide a more cost-effective plan for these. That's where we stand at this point. Maybe there are some things out there that we don't know about, but that's pretty much how the conversations went. We have had numerous conversations. I think it's very important to say that as the Affordable Care Act rolls out with the various requirements for employers, including all the various health systems, et cetera, that it's very important that we work together with the Department of Education and with local school systems to make sure that we address their needs. So we encourage that. We encourage input and anyone's questions on any of these plans.
So at this point, nobody has left?
No, ma'am.
No, they've just talked about it. Thank you.
Just a little sidebar to that. One of the state agencies, Congress Center, went out on their own, and I think at the beginning they're going to see some savings, but the problem is going to be they've got the younger, healthier group. And then, when, as the commissioner said, when you look at taking the entire group and us older folks that cost them more money and stuff like that, it's going to be a little more for that to take over. Okay, we have any other questions? Representative Dollar.
Hey, Commissioner. I have a letter here from October of last year from the various or from the respective chairmen of both appropriations committees, and it's a letter. It's regarding the bariatric surgery program that I had, referenced. I believe we referenced it last year in this very same meeting, and there's I believe 6 questions here that I can get with you on later specifically, but I was kind of curious as to I want to say that we had put in either 1.5 or 2, somewhere in that neighborhood, $1 million for the program, and I didn't see it in this latest budget. I was just wondering what happened to that. What happened to those funds?
Well, the funds within the state health benefit plan were applied towards state health benefit plan funding. With regard to bariatric surgery, as you know, we eliminated that benefit, I guess it was about 1.5 years, 2 years ago. We found that with the bariatric surgery issue, we had about 1,900 people that took advantage of that. We found that most of those people, probably about 60%, 60% of those who were enrolled primarily to gain access to that benefit. So they enrolled in it, had the surgery, and left the plan. About 60%. Of the remaining 800 people that we tracked over a 3-year period, we did not see a decrease in the expenses associated with their care. So we had lower pharmacy rates expenses, but higher medical rates. So overall, we had adverse selection with the bariatric surgery issue, and we had the increased expenses. Had a meeting just a little while ago regarding the issue, and this is a population that we are tracking over time to see if there are savings that can be achieved. And when we get the plan on a more stable financial basis, I think it's definitely an issue we need to take a look at, maybe adding back.
Mr. Chairman, follow up. I'm sorry, did you say it was 3 years that y'all were tracking that data?
There were 3 years. We had the surgery for 3 years, and I think it was, 4 or 5 years ago that we implemented it.
Okay, so y'all were tracking those figures.
Absolutely.
Okay. And
it was a very expensive surgery, about $20,000 per surgery.
And did the department feel that 3 years was long enough to look at some long-term type of analysis?
Well, I think it takes about 5 years or more to really get a good handle on that.
Mm-hmm.
What we were faced with, as I mentioned earlier, was an $815 million deficit.
Yeah.
And we were looking for various ways to have the best utilization for the money, the best bang for our buck, if you will. That included a lot of plan design changes that we made to bring that deficit down from $815 million down to $62 million. One of the reasons that we chose a elimination, which I think is one of the few benefits we eliminated, was because it impacted a relatively small number of people who had a very high cost procedure that did not show over the period that we had, 3 years, any cost savings. So we'll continue to look at that, and I think people indicate that there's about a 5-year timeline before you see cost savings on that, but we'll continue to look at it over the continuing years here.
Okay, and one last follow-up, Mr. Chairman. So I know we eliminated the program, but again, 9 months, a lot happens to. We did not put any money back in the budget for this program last year.
Well, the money was appropriated to the state health benefit plan.
Okay. All right. Thank you.
Thank you, Mr. Chairman and Commissioner Cook. Appreciate your service. I have a question about you've given us some different numbers about the expense growth and enrollment growth. What was the expense growth in the ABD population? Did you say 16%?
6.2.
6.2%. Okay.
In expense and enrollment was 4.1%.
Okay, and when I compare with Medicaid, low income, I believe your expense growth was 4.1%.
Yes, ma'am.
There's a couple percentage points there. Do you know what the difference is between the two programs?
I'm going to defer to.
Okay. In the ABD, there was an expense growth of 6.2%. While low-income Medicaid was 4.1. Can you explain the difference and why there was the?
Sure. In terms of the growth rates, if you look at growth rates for eligibility, for example, to start with that, there was a backlog in the federal government for disability determinations. We've seen somewhat of an avalanche of those come through. Disability determinations were made at the federal government, not the state level. So that's been something that was kind of out of our control. If you look at growth from the expenditure side, this population, again, is a very high acuity, very intense needs, very sick population. And so it is also, I'll call it an unmanaged population. We process claims, we set policies, we set limitations, but at the same time we don't have active care coordination, case management, disease management, interventions to try to drive utilization to that level. So those are two of the reasons.
Thank you.
Mr. Chairman, may I clarify a statement that I made to Representative Gardner? 29,000 that I quoted is actually our number for the year. So the count of members is actually 36,000. So slight difference there. I just wanted to use the opportunity to clarify that.
Thank you, Mr. Chairman, and thank you, Commissioner. I wonder if you would explain to me on the expenses for the wellness program. I think I'm understanding that might be a source of savings for the health insurance plan, and I'm wondering. I think you commented on the fact that it was costing more. Did I misunderstand you?
No, you didn't. I think typically when you engage in more hands-on management of particular diseases, you have more upfront costs associated with that. As similar to bariatric surgery, it's going to be several years down the road before we see savings associated with that. What we did in the first year of the wellness plan is get a benchmark or a baseline, if you will. And now that we have that, we'll be employing various mechanisms with coaching and various other things in order to try to address that. So that's an additional savings associated with that wellness program. Not savings, but expenses, I should say.
So the data from of course, you've only had 1 year, is that correct?
Yes, ma'am.
So there's really no data that supports or takes away from it right now.
We've got about 45%, I believe, of our enrollees in the wellness plan.
Okay.
We now have a group of people that we're going to be able to watch and track over the years, and hopefully target their needs and do some things to get a healthier population and a less expensive population.
Which in the end will be beneficial.
Yes, ma'am.
Okay. Thank you.
Thank you. I'd like a little more information on how the elective early deliveries issue is going to actually work. I think the data is really strong that it's certainly the best thing to do, but how is it going to work in reality? And is it going to guarantee improved care?
Again, I might let Dr. Doubly address that specifically.
So with the 39-week elective induction C-section effort, what we don't want to do is just create an administrative burden or hassle. So what we're doing is we're working on our coding system so that we use certain modifiers that indicators on the claim can indicate where the individual is within their gestational period and whether or not that the induction or the C-section is elective or non-elective. So we're looking to do this on an electronic basis so as to not create a burden. In terms of whether it will or won't, I think there's good data that if we can get close to that 39 weeks at least, if not past that, there are better outcomes from both a learning standpoint, from a lung development standpoint, etc. So we do think that we will see the outcomes. The good news is that the provider industry has done a great job of self-monitoring and regulating, and they've really done a good job of that. And this will just use the policy to reinforce that.
Are there savings that they're able to talk about from the changes in their procedures?
I couldn't speak on their behalf. I've not had them present that, but that's something I can reach out to them and see if they have something.
And so it'll be like a prior approval program. I mean, you're not just going to refuse to pay the hospital for delivering the baby.
Well, it would be a post-approval type situation where if they
After the baby's born, right?
On the claim that it was medically necessary and they were past 39 weeks, we would deny those claims, but we wouldn't have a physician in a delivery room who has to stop and get an authorization before they do a C-section. That's obviously not. It's all back in.
Well, we need healthy babies, that's for sure. I have one more question. Thank you. You're so generous with me. I have heard about an adult daycare licensure act that was passed several years ago, but there was never any funding to set up the procedures for the adult daycare licensure act. And I'm told that if people could go to a licensed adult daycare facility, they might get some help from their long-term insurance. And I mean, we want to keep people out of institutional care if we can. So what is going on with that, and is it something you've decided is not a good idea? Is it I mean,
don't
it's
think
sort
that's-
of one of those laws on the books that you don't know. Would you
I don't-
would you see what you can find out
Sure.
about it? I have a group of people who are very interested in that. Thank you.
Any other questions? Commissioner, thank you for a good presentation, but before you get out of here, would you talk just another minute or two about the provider fee, what that would generate if it's reauthorized, if it's not reauthorized, what the hole would be in the budget, and what would you anticipate it would take to fill that hole? And as I understand it, we're kind of locked in with some of your choices because with your maintenance of effort, you can't, affect like the eligibility and do some things like that. So really one of the main things that you're left with, it seems to me, is looking at the fees that you're paying to providers across the board. And I think most all of us would agree, I don't know of any of the providers that are getting rich at the fees they're being paid now. And my concern is if we were to have to go in there and cut those fees 18%, 20%, whatever that number is, that we would have people in facilities like hospitals and others who just financially wouldn't be able to make it. And then you run into the problem of access to the health care and this and that and the other. Would you talk just a little bit more about that, please?
Sure. I'd be glad to, Mr. Chairman, and I think it might be helpful to go to slide 30. You probably have it up there. Yep. Thank you. I guess one of the points I would make is, and this committee knows this probably more than anybody, the challenges we have in funding the current Medicaid program that we have, and that's assuming that there's a continuation of the hospital provider payment fee. We have asked for additional funding this year in terms of growth for that for the Medicaid program, and we're struggling to come up to meet just regular normal growth within the program, much less the loss of a significant amount of money that is related to a mechanism to draw down additional funding. I talked earlier about the FY13 impact. That is the law that's in effect. The issue I think you're referencing is whether the General Assembly reauthorizes that. And with the reauthorization of the provider payment agreement, you can see the FY14 numbers there. We would estimate about a $241 million fees that we would generate from that provider fee, and that would generate, as you can see on the very bottom right, about $707 million. That's a lot of money, and that is a hole that without that money would be a significant hole within the Medicaid program. The way the provider fee works is that fee is collected, and then in this particular case, the hospitals are reimbursed as an industry as a whole a little bit more than what they've paid in. About $258 million is what we'd estimate in 2014. And then we would generate with that provider fee an additional almost $450 million. So if we were not to have the provider fee reinstated, we would be looking for a total amount of money of about $707 million. The current growth rate is what, $200 million? $200 million, just to put it in perspective. That would be a significant additional hole that we'd be looking to fill, and our, as you said, our ability to manage to that would be very difficult because our ability to impact eligibility or scope of benefits is restricted by federal law, which would really leave us down to rate cuts or some other things that would be pretty significant for the industry as a whole.
And just to follow up on that a little bit, the nursing homes now have been doing this for some years,
Yes,
and the upper limit is like 6%,
Yes,
and
sir.
they're basically there, you might say. And then we're just finishing up the 3 years on the hospital provider fee, and it's my understanding that basically the hospital community has sort of come together and felt like this was a good opportunity to help to come up with that money, because I'm just really concerned if we have to go in there and try to find that $707 million, that there's going to be a lot of folks who are really going to be unhappy about that, and providing the services and the providers that are out there.
Yes.
Thank you. Do we have any other questions? Well, thank you, Commissioner. Thank you for what you're doing over there. You and your staff, you all have a very difficult job, and you're doing a good job handling a tough situation.
Thank you.
We'll give the Commissioner a minute or two to get everything together, and next we're going to hear from Sherry Tucker and the Georgia Board of Physician Workforce. Folks, if we could, we're going to go ahead with our meeting, so if you could please sort of close up the doors, and if you have conversations, you might want to move those outside, please, and we'll go ahead and continue. Sherry, go ahead. Pull that mic up close, Sherry, so it's talk right into it. Please, ma'am. You don't have many ads on your program, do you? Okay, we've got a question here. Is it Representative Hughley? Is it you? Okay.
I'm sorry I had stepped out of the room, but would you go over again the Morehouse reduction and why it's that way?
The Morehouse operating grant, the state puts in 10.6 million, almost 10.7, and they also receive federal matching dollars for this money. And so if we reduce the state funds 329,000, the matching funds they will lose on that makes it a total reduction of almost $1 million.
How do we figure out if this is a, your ROI? How do we figure out the return on investment when it makes sense to make that kind of a cut? For us to make that kind of a cut, how do we figure out if that's a good use of our money when we look at return on investment?
I've got figures in the office on return on investment. I don't have it with me.
Uh-huh.
Get that information to you.
And then the last question is, as you said, the last thing you said was the programs had sustained a large number of cuts over the last several years. At what point, or have we got to diminishing returns? Are we there yet? No.
Our programs, training the physicians for the state, we are definitely increasing the physician population in the state that's providing the services to the citizens of Georgia, and it is a very good return on investment and bang for the buck that we're getting.
So you're saying that these cuts really don't matter? We're still getting all the physicians that we need here? Is that what you said?
It doesn't matter. I'm sorry. I understood what you said. The cuts are major to the programs. I've asked for impact statements from all of our contractees. They're due in February 1st on that. For some of the medical schools, what I've been told, I haven't seen any writing yet, you're talking about possibly faculty cuts, which would increase class size cuts, where the impending physician shortage as healthcare changes over the next few years and the population ages, we're going to need more physicians. And if we stop that pipeline by keep cutting these programs, it's going to just create more problems and more backlogs of citizens trying to find healthcare.
Thank you.
Other questions? Sure, I've got a couple of questions. Let's talk a minute about 17.10.1. This is the removal of those bridge funds for your Gwinnett Medical Center in Southwest Georgia consortium money, $826,000. I've had several folks talk to me, and I'm sure you've had some talk to you as well. And I have some concerns about what we're doing there. This committee last year, the governor wanted to increase the number of slots, residency slots in Georgia, and I think we all thought that was a great idea and went along with what he had recommended, and in addition to that, put some more money in there to go into those slots. But I'm concerned that where we thought some of this money was going, it's being removed from that area and going somewhere else. And tell me, haven't you already got some contracts with some of these folks and some of these slots that are going? And if this money comes out of here, how are you going to pay those obligations, I guess is my question.
We do have contracts with both Gwinnett Medical Center and the South Georgia Consortium.
Mm-hmm.
We have one invoice in-house now from the consortium. We haven't received any invoices yet from Gwinnett. And I know another invoice is on the way from the consortium on that. If the funding is totally removed, we would not be able to pay those invoices based on the contract.
Mm-hmm.
Our contract is the standard state contract that bases the contract on the appropriation. So everything's kind of at a standstill right now with that. And it would create a major slowdown with what the consortiums do, and their executive director is here to speak to public comment
Yeah.
on this. I do have an impact statement that I included in the packets from them as well on that. We did take this money. We had been working with Gwinnett and the consortium for over 2 years. Our board has. And in Gwinnett, we provided minimal funding. The consortium just input to them and did not provide any funding until this was put in our budget. But we worked with the Board of Regents on their funding as well for the 400 resident slots, and the Board of Regents funding that they provided to both facilities was based on this appropriation as well. If this money had not been in our budget, the Board of Regents could have possibly given them more money. I don't know, but it was definitely based on this state funding as well.
Yeah. And help me remember, I believe the consortium had raised money on their own, about $1 million or so down there, didn't it, that they were willing to put into the program to help to leverage some state funds so we'd have a public-private partnership there to do that?
Each one of the hospitals put in $100,000 over several years to help get this project going.
Okay. We'll talk about this a little more. We got a question here from Representative Shelton.
Thank you, Mr. Chairman. And I apologize, I stepped out for a minute. So, but this item definitely piqued my interest. Not sure why. But I see, there's been it's definitely important to be funding the residency slots, but there's a reduction of $800,000. So is that coming from, was that the governor's recommendation? Was that your recommendation? Or who will fund these 400 slots if we approve this reduction?
This reduction is the governor's recommendation.
Okay.
If this money is removed, I don't know where the funding would come from. I do know that the money that was provided to the Board of Regents, they issued contracts to 4 facilities on that, and it has a balance of around $80,000. That's all they had left of the $1.2 million they were getting for 13 for the rest of the
Thank you. I'll definitely have some questions later about that.
We're going to have to get into some new math to make all this work out there on that. Here, on the 17.13 area there, the rural physicians for rural areas, talk to me a little bit about that. I know that's to help repay some of their student loans, I think, and if they work in the rural areas. How much is that? How many doctors do we have in that? And what's been sort of the history as far as the amount of money that has gone into that program? As best I can remember, we really haven't increased that anything to speak of lately.
We have not increased that. The program, there's 2 pieces of this in here. There's $500,000 for scholarship program, which we expended all of that when we did interviews back in July and August. And that is paying for medical students to attend Georgia residents to attend medical schools in the United States, and they receive $20,000 per year. And they have to practice in a Georgia county of 35,000 population less when they finish their GME program. The loan repayment program is for physicians who have graduated from their GME and to pay off their medical education debt. The board will be meeting Thursday on this. We have $330,000, and if they award $20,000, we can give 16 awards. And we have 28 applications. And the probably average debt is 200 or more. We do have a couple that has 300,000 or more in medical education debt on that. There is a ranking system the board uses based on the specialty, the need of the county they're in, the amount of debt, and type of practice that they have to rank the applicants on that. The program, this is one of the programs, it's with the scholarship and loan repayment, it's been reduced 24% since 2009. So there is a lot of interest in it. We have, I was just looking for some of my notes here on the loan repayment program. The states invested a total of $4.4 million in loan repayment in the 18 years the program's been in existence. We have 104 positions remaining in Georgia that have produced approximately 1,300 jobs. And this year that will produce between 78 and 156 million in economic activity on that. And for every 20,000 spent on a loan repayment, the state has yielded 354 to 709,000 in economic impact.
So it's pretty significant. And help me remember, when we discussed this before, we were talking about how this program was administered. And those students, when they borrow that money up front, they have to make that commitment like their first year, don't they?
On the scholarship program, they
Yeah.
have to make it their freshman year, first year in medical school. And there are some that once they get into it, they'll relinquish their scholarship because they've decided they don't want to go into primary care or work in the rural area. But they're still obligated for the length of time they did get the scholarship. If they totally default, it's triple damages. So if they go to 4 full years at $80,000, they have to pay back $240,000 within 90 days of finishing their GME program.
And that was one of the things we wanted to look at to try to see if we need to tweak that to make it more attractive, because sometimes when in their first year of medical school they might decide they're going to do one thing, but by the time they've been in there a couple of years and had some time to be in school and do some practice work, they've decided that they might want to go in another direction. But the penalty is so severe that it really, I think, frightens a lot of them from doing that. So let's...
We do have better results, I can give you that, with our loan repayment program, which was given after the fact, after they finish their GME. The scholarship results are good. They're not bad. They are good. But the loan repayment results are better.
Works better. And that loan repayment's like $20,000 per year.
Currently, they have gone as high as 25.
Depends on how much money you have and then how many apply.
Right, exactly.
Yeah. And that money doesn't go directly to them. It goes to pay the loan off, right?
Directly to their lender.
Yeah. Okay. Anybody got questions? Any other? Well, Sherry, thank you. We had a list here for anybody that wanted to make any public comment while we're here. And we've had one person that signed up, Jessica Rivenbark. If you just come to that and just speak right into the mic, I think we've got it on there for you.
I just want to thank you all for your support last year of the funds for the South Georgia Medical Education and Research Consortium. We have been very busy applying for our institutional accreditation and recruiting our key medical faculty to help support the programs in Southwest Georgia. We were a little shocked and surprised when the recommendation came out to cut the funds this year. We have been working collaboratively with the Board of Regents, with Sherry Tucker and the Workforce Board, as well as our main academic affiliate partner, the Medical College of Georgia. Just wanted to make a statement, if I could, that the elimination of these fundings is going to be pretty devastating to our progress and future plans. We signed the contract with the Workforce Board November 27th. We have been in the process and are in the final inches of signing a contract with our Chief Medical Director, who will serve as our designated institutional officer required by the Accreditation Board. We also have been preparing our hospitals. We have 5 member hospitals, 4 of whom do not have programs. Phoebe Putney in Albany does currently have a residency program. There are required facility accommodations that each hospital has to have in order to be accredited. We've been in the process of preparing those hospitals, so we have some rather significant expenses coming up in order to finalize our accreditation with the national accrediting body for these programs. The contract with the state funding was instrumental for our local hospitals and local CEOs local communities to show the commitment with the state. And without that funding, we will be in significant jeopardy of being able to continue on the path to have residents on the floor July 2015. So I appreciate your consideration of trying to help get those funds reinstated, and anything I can do to provide any additional information, I'm happy to do so. And thank you very much again for your support and your willingness to have me speak for a few minutes.
Thank you for taking the time to come up here and share with us your concerns on that. Do you have any questions of anybody on the committee while Jessica's here? Dr. Watson?
Thank you very much for coming. Could you just give us a little details of what you have planned for the residency programs? I mean, are we talking family medicine, internal medicine, pediatrics, OBGYN, and how many residents per year?
Yes, Mr. Chair. We currently plan to roll out in our initial year, which we're starting accreditation now, an internal medicine program. We plan a total of 36 residents in that program. Our primary site will be South Georgia Medical Center in Valdosta. Our participating site will be Tift Regional in Tifton. We also plan to roll out that initial year a family medicine program, which we're going to shoot for accreditation for 18 family medicine residents in total. That will be based at Archibald in Thomasville, and the participating site will be Colquitt Regional in Moultrie. Subsequently, we will roll out an OBGYN program and general surgery program that next year. And then we had originally planned to do a pediatric program. Right now, we're actually considering an internal medicine peds program just because our part of the state, we don't have the subspecialists to support the requirements for a pediatric program. It would be cost prohibitive, as well as an emergency medicine program. Most recently, we also have been exploring the options of doing fellowships and a family medicine rural track, which would include students who did their first year at an urban site and then came down to South Georgia to finish family medicine. So all primary care based, and in this instance, we're considering general surgery primary care because we're not subspecializing in general surgery.
Jessica, if you would, why don't you put together for us just a little simple one-page white paper, maybe outlining what you went over right there, and get that to us, okay?
Absolutely. Thank you.
Good. Any other questions or comments from the committee? Representative Gardner, I'm sorry.
Well, I just thought of this question. I went over and visited CHOA's telemedicine program, which is wonderful. And they had a experience with physicians from all over the state calling to find the specialists. And I asked them what 75% of the calls were for, and they were for mental health. And they have apparently one psychiatrist at the Marcus Center to help with those questions. And I just wondered, are you expecting any use of the telehealth system or expanded use of it, and how will it work?
Actually, that's a great question. Thank you. Archibald Medical Center in Thomasville is a key leader in the state in telemedicine, and they do several programs. They have a conference every Thursday, I think, in telemedicine where they have doctors that convene and do showcases through telemedicine. So they have, yes, of course, brought that to the table. And with our 4 participating sites, as well as Phoebe being the 5th, we absolutely hope to utilize telemedicine and telehealth and come out, because we're one of the first groups of hospitals that have come together to do residency programs, and we actually hope to showcase our residents and possibly do grand rounds and use that technology. Yes.
With behavioral health issues?
We actually, early on, they explored looking at psychiatry as one of the residency programs. Unfortunately, it was off the table largely because of the impact to the area and the fact that we don't have a lot of subspecialists to do the required rotations. But we certainly did talk about it and the importance of mental health and behavioral health.
So there was a need for it through the telemedicine.
I can explore that option and get back to you. Absolutely.
That would be helpful to me.
Sure.
Okay, any other questions? Okay, thank you very much.
Thank you
we
for your
appreciate you
time.
being here. That concludes this part. Let me just remind you, those that are here, the members and our guests, that tomorrow from 2 to 4 in room 341, we're going to have a sort of a Medicaid 101 program. Folks are going to come in and be able to talk and give some information, especially, I think, to our new members who maybe have not had an opportunity to deal with some of these subjects. I think just more of an informational sort of a situation. And then after that, Margie, we have the public health will come and present their budget after that. So that'll be tomorrow in room 341. We'll begin at 341 at 2 o'clock. So thank you all for coming.